Thank you. Good morning, everyone. So my name is Thais. I am a technical director based in Mozambique. I work for ICAP. So yesterday, my colleagues have already talked about a little bit about Mozambique, but just to remind, according to the population-based HIV impact assessment, the estimated HIV prevalence in Mozambique is 12.5%. More than 2 million of people are living with HIV. And when we look at the 95 cascade in individuals from 15 to 24 years, which is what I'm going to talk about adolescents and young population, the first 95, we can see that only 54% are aware of their HIV status, HIV positive status. And I don't want to bring additional fire on the discussion we have this morning, but I think this is very aligned with the discussions we were talking this morning regarding how it is important to identify those adolescents and young population. We are very behind of the targets. We need to address these challenges. So what we did, we discussed it with in collaboration with the Ministry of Health and with the provincial leadership. ICAP has been working in 62 health facilities in Nampula, and we designed a model of service to offer those integrated service at the community level. So we work with the governments, with the provincial representatives, including private sector. We mapped where those adolescents and young population from 15 to 24 years old were congregated, trying to respond where, when, and how, aligned with the DSD service. And then we defined the package and model of implementation, and set indicators to collect and analyze data. So the model and package of service that we provide for those adolescents were integrated at the community basis. And the status neutral approach was integrated, which means that no matter of what was the results or the needs of those adolescents, there were adolescents that were coming just for grab condoms or to participating in create demand activities that I'm going to explain. So it was integrated, the services with outpatient consultation, family planning, and others, as mentioned here. One important point is that the healthcare workers were trained to offer the services non-judgmental, because we know that adolescents and young population, they want to talk about sexuality, they have a lot of challenges, and somehow they feel that health facilities are very feminized places for women that are seeking maternal health services in general. So we allocated mobile clinics for secondary school students. So why we did that? Because we mapped where they were congregate, and during the weekends, on a monthly basis, the mobile clinic brings services, these integrated services. As I mentioned before, we added some recreation activities, so sports competitions between the schools, and we involved the local authorities to create demand and bring those adolescents. We also use another strategy which we call mobile brigades for technical schools and university students. So the difference between the first one and this one is that we use the available space in these technical schools. So we avoid to bring those vehicles. So comparing to the first one, it was more cheap and simple model. We engaged with the leadership of these technical schools to promote the HIV literacy, to create demand for those adolescents. So for example, these ones that we are seeing, they are adolescents, and also part of them, because Nampula is in the north of the country, are also IDPs, so internal displaced population that moved from Cabo Delgado, which is a place where there is an armed conflict in Mozambique. So if we look at the results, more than 1,600 adolescents and young population attended those mobile brigades. So the two models that I showed. 1,190 were tested for HIV, and 30 were tested positive, and all of them linked to treatment. We can see that for those that were eligible for PrEP, 97% were initiated oral PrEP, and 94% initiated oral PrEP among male and female, which is very high. So looking to my conclusions, we can see that community services that were designed for those adolescents were successful to reach this population, and also the status neutral approach improved this care in treatment services, while we address the needs of these adolescents. And an unusually high percentage of males were reached, and demand and acceptance of PrEP was high among boys and adolescents males. Thank you very much.